Sir, you can start, sir.
Okay. Hello all and welcome. Welcome to this another session of the osteology of upper limb that we are referring right now. So guys, this over here, yesterday we discussed about the proximal bones in the upper limb, that is the clavicle, the scapula and the humerus. And today we are going to move forward from that. And today we are basically going to discuss about the two important bones of the forearm, that is the radius and the ulna. So here we have over here the two bones. This I hope you can identify. This is the upper end and that is the lower end. This is one bone. And this over here is the second bone over here, upper end and the lower end. So I guess by just looking at it, we should be knowing that this second bone over here is the ulna. And the first bone over here, that is actually the radius. Okay, so in detail, we'll discuss it, how to identify them and the site determination and the various important attachments. So welcome all, I'm Dr. Ankit, faculty in the Auricle for anatomy. And these classes and these sessions are going to be useful for your prof exams as well as for the MCQ exams. You can use the code below Dr. Ankit 20 for various discounts on other subscriptions. These are the questions that can come from the radius and ulna bone. Take the screenshot of this. So long questions can come in the form of, let me read out a couple of questions. Long questions: describe the radius and ulna bones in detail. Discuss their anatomical position, structure, ossification, and clinical significance, with emphasis on fractures and common clinical conditions, basically everything. The short essay questions over here can come like discuss the interosseous membrane between the radius and ulna, then include its attachments, function, and clinical relevance. Other question can come as explain the blood supply and innervation of radius and ulna. Highlight the important arteries and nerves involved. Or question can come like describe the supination and pronation movement of the forearm. Focus on the role of radius and ulna along with the associated muscles. Other short answers questions can be like, what are the common sites of fractures of radius and ulna? So other fractures over here. Define the radial tuberosity and its function. And what is the anatomical snuff box? And what is its relation to the radius? So these are some of the questions which can come. Okay. So why to choose Auricle, guys? We all should be knowing by now, and these are various benefits of Auricle: recorded classes, live classes, hard copy notes, doubts clearing, and other benefits, QBank, and your practical sessions as well. These are the subscription plans of the Auricle. Here we have all the range from 3-month plan to around 4-year plans that you can see over here, from 3 months to 4 years. In between, we have a 6-month and a yearly plan as well. There are various prices over here, and you can also use the code for various discounts on the subscription. Okay, so let us come back to our topic of discussion today, that is the two bones, radius and ulna over here. Okay, let's move ahead and start with this particular topic over here. So this was the previous session. We discussed about the humerus in detail, and that was the end of that part. In this session, we are going to start with the radius, and then we will come to the ulna. And basically, both of the bones can also be learned simultaneously because they are lying side by side. They are lying side by side, meaning by, if we look at our forearm, this is the forearm from elbow to the wrist over here. This is the forearm part. Here we have two long bones. One laterally towards the thumb side is the radius. So laterally we have the bone that is the radius, and medially we have the bone that is known as ulna. Remember this first of all. That lateral towards the thumb side, we have the this is the radius over here, and this must be the ulna. And ulna projects over here as the olecranon process, that is the point of elbow. This much point is clear, right? Now, similar to the upper limb, in the lower limb also we have the region of leg. In the leg also we have two bones. In the leg we have a bone on the medial aspect, and that is known as the tibia. And in leg on the lateral aspect we have a bone known as fibula. Okay. So in the forearm we have lateral and medial bones as radius and ulna, and in the leg we have the medial and lateral bones as tibia fibula. So the questions have come that, okay, radius bone in the upper limb, radius bone in the upper limb is homologous to which bone in the lower limb, is homologous to which bone in the lower limb. That question has come a lot of number of times. They can either ask radius or ulna. So radius over here, being the on the lateral aspect, looks like that it must be homologous to the fibula over here because it is also lateral. But answer over here is not fibula, answer is tibia over here. Is tibia over here. Why so? That also understand that if we look at our upper limb, then the thumb lies laterally. And if we look at our lower limb, the foot, there you'll see that the great toe, it lies medially. So if you compare the upper and lower limb, then we have the difference in rotation during development. That is, during embryonic life, there's a difference in rotation. Upper limb having 90-degree rotation laterally and the lower limb having 90-degree rotation medially. So there's a difference in rotation of both upper and lower limb. Therefore, the radius is not homologous to fibula, it is homologous to tibia. And similarly, the ulna in the upper limb is homologous to fibula in the lower limb. Remember this basic first point. Now there's one more difference in the upper and lower limb bones over here. What is that difference? If you look at our hand, if you look at the upper limb, you can see it is rotating like this. Can our lower limb also rotate like this? Can we do a screwing movement like we do from the upper limb? Can we do such a movement so easily with our lower limb or our foot or our leg? Answer is no, it is not like that. Therefore, in the upper limb, that is basically we are referring to the two bones over here right now, radius and ulna in the upper limb, in the related to radius and ulna. We have a different set of movement totally. So there's a different set of movement totally in upper limb, and that is known as supination and pronation. What is that known as? Supination and pronation. And this movement, supination and pronation, basically occur at the radio-ulnar joints. So this movement over here, which joints allow this movement, the joint is between the radius and ulna, known as radio-ulnar joint. That is also one important differentiating feature of the radius and ulna compared to the tibia fibula of the lower limb. So therefore, as you will see the bones, we will see that, okay, the radius is rotating around the ulna. And there's a radial notch in ulna and there's a ulnar notch in radius. So there are two notches in both the bones. In radius, we have a notch for ulna, and in ulna, we have a notch for radius. Understand that part. And in the supination pronation movement, the supination pronation is simply screwing movement. Okay, this movement over here, this is supination pronation. So this is supination and this is pronation. This movement is supination. When doing like this, supination, and doing like this is pronation. We remember it by the mnemonic that beggars, they supinate. The beggar is asking for some food or money, they will supinate. And the priest giving blessings to the people, the priest will put a hand over the head like this. So priests, they pronate. Remember this, that simple mnemonic might help you, that priests, P for priest pronate. And for the supination, beggars supinate. Beggars, they will supinate. Remember this. And this basic movement is between radius and ulna. Now, there might be a question which the examiner might ask you, and MCQ might come is, does both the radius and ulna, they both contribute in the supination and pronation? If yes, then have they equal, do they have equal proportion or equal contribution in the movement, or one is having more contribution? The answer is that radius is having much more contribution than ulna. So in a pronation and supination, the component of radius is much more than ulna, or the involvement of radius is much more than ulna. Or basically, there's much more movement of radius compared to ulna in the supination or pronation. Understand this part. That is just telling you that in a nutshell, there are two bones in the forearm. Lateral is radius, medial is ulna, and they are homologous to respective bones in the lower limb. The other feature over here is that they have another set of movement, that is supination and pronation, which occur between these two bones. The third thing you should understand in the beginning, okay, that you can imagine that, okay, there's a one bone over here and there's one bone over here. Suppose say this is radius and this is ulna. and they are forming a joints over here. Let me just highlight this area. There's a joint over here, there's a joint over here. So they're moving around also. Fine. So is it that simple, or there's some other structure also over here? Can't they rub against each other so they can put pressure to each other? Therefore, what happens is between these two bones, this border over here, this border of the ulna and this border of the radius, between these two, you have a structure that is known as interosseous membrane, which I guess if you have learned the general anatomy in detail. And in general anatomy, we discussed a topic known as the joints. In joints, this example came of interosseous membrane. So there is always an interosseous membrane between the two bones of the forearm or the two bones of the leg also. So this interosseous membrane, what does it mean? Interosseous, that between the bone, I have a membrane. It's an example of which type of joint. It will come basically as an example of fibrous joint. Okay. So there is always an interosseous membrane between these two bones and their adjacent borders. It will be same in tibia fibula also. What is the use of this bone? Obviously, it is aligning both the bones so that the both does not obstruct each other function. And simultaneously also, apart from this, what will happen is, slowly as you will see that there are a lot of muscles attached to both radius and ulna. And therefore, interosseous membrane helps in attachment of, or it helps in giving the increased surface area for attachment of the muscles also. So that is also one added use of interosseous membrane. Okay. I hope this point is clear. Now let us see the bones first of all. Let us see just one page of radius, what is the writing, and then we'll come to the bone. I'll show you, demonstrate over here also. So question can come like, okay, explain about the radius bone. Okay, explain about the radius bone. So radius is the lateral bone of the forearm, fine, homologous with the tibia, as you can see. It has an upper rounded end and lower broad end with a styloid process and a shaft. So here you can see the radius bone in this image. This is the upper rounded end. What is this? This is upper rounded end. See it carefully, it should identify it by this. And lower end you see is quite broader compared to the upper end. So this is lower broad end. Lower broad end. Now let me show you the bone over here. Okay, there you go. Okay, now I'm bringing it closer to the camera. This is which end? This must be the upper rounded end. It is like cylindrical like this, and above you can see there's a concavity over here. I hope you can see it very well. There's a concavity. Here, which bone will come and attach at the upper end of radius? It is forming the elbow joint. So which bone will come over here? It will be the lower end of humerus. And lower end of humerus, there was which part of the lower end of humerus will come and attach over here? Yesterday we talked about the
Capitulum, sir.
Right?
Capitulum.
Yes, it will be the capitulum. So let me show you the humerus also over here. There's a humerus we discussed yesterday, upper end having the head, and there's a lower end over here. Okay, so this was the trochlea part. This bigger one, this is a medial aspect, trochlea. This you can see the rounded part. Okay, I'm bringing it close to the camera. You can see the rounded part. This whole is capitulum, and therefore this capitulum over here will fit on the concave upper surface of the head of radius. So this is also known as the head of radius, having the upper concave part. This you have to understand. Okay, this helps in the formation of it's a part of the elbow joint. It's not a complete elbow joint, it's just a small part of the elbow joint. So this you can identify. Now you can look at the whole shaft. Yes, come to the lower part. This is the lower end. Lower end is broad. Now compare it to the upper end. Upper end is like this head. Look at the size of lower end. So lower end is broad, and you can see one side is tapering. One side is tapering. This part or tapering part of the lower end of radius is known as the styloid process of the radius. What is that known as? Styloid process of the radius. Okay. Now, I'm just telling you how to identify the radius. I hope you can easily identify with the upper rounded head and the lower broad end. Now, then comes a point, is it of the right side or left side? Identification, you can identify without touching the bone. It is placed at 4 feet away from you. You can say, okay, it is radius. Then comes which is the side. There are 2-3 things which you can understand which will help you in understanding the side of the bone. What are those? If you just touch the bone over here, if you just touch the bone over here, you will feel a sharp border. You'll feel a sharp border. Let me try to show you. Can you see this sharpness? Try to
Yes, sir.
understand. Okay. So this sharp border is known as the interosseous border. What is it known as?
Interosseous border.
Okay. So this interosseous border is facing the ulna. It is facing ulna.
Okay, sir.
So this side should be the medial side. But it can be of the left forearm also. And if I rotate it like this, then it becomes of the right forearm. Because now the interosseous border is over here. So if I attach it onto my right forearm, I can say, okay, it is of right side. But then the examiner will say, okay, I turn it around like this. Now it is fitting on your left forearm. So only one point is not enough to tell it is of the right or left side. This point is correct, but it is an incomplete point to tell about the side of the bone. So now, what else will help you? Now, if you come to the lower end of the bone, this is the lower end of the bone. Now there will be few tubercles over here. Can you see the? You can see the prominent tubercle over here. And
Black color.
yeah, and you can see a few other elevations over here. This you can, even by seeing, you will understand that this area is not smooth. But if I turn it around and I show you this A part, you'll say, yeah, this appears smooth. There's no prominent tubercle coming over here. This appears smooth. And this appears over here having a lot of tubercles. So this surface having a lot of tubercles is present on the posterior aspect. So I have to keep it like this. And this will come on the anterior aspect. This clear part, because here we have the radial artery also. And radial artery is best palpated. Now let me come to the practical part. You have the wrist over here. You go to the lateral side, thumb side is lateral side. Palpate over here. You feel the pulsations of the radial artery. The radial artery will lie over the smooth surface. Common sense. If the radial artery is lying on the posterior aspect over here, then once you palpate it, then the artery will be rubbing against the rough edges of the tubercles. So artery is placed in front of the smooth part. Therefore, the smooth part on this particular bone, this part should be lying in front. Now look at the complete picture. This part is lying in front. This styloid process is projecting laterally. Right?
Okay,
This
sir.
styloid process projecting laterally. This part is lying anteriorly. And you can feel the bone. This is the medial or the interosseous border. Because it is facing ulna. So this bone is radius, it is lying laterally. So medial to it, you have the ulna. So now this will be, now if the picture is clear in your mind after 5-10 seconds in your Viva Voci, you'll pick up the bone, so it is radius, then you'll try to feel it like this, interosseous border, anterior part is smooth, and try to just act like you are trying to fit it in your forearm. Then you'll say that this is the radius of right forearm or right hand side. Done. Now you are 100% sure in giving the answer.
Yes, sir.
This forms the first 2-3 initial questions in a hard part Viva. Identification of the bone and the side of the bone. These are 2-3 main points. Anterior part is smooth, posterior you have tubercles. This tubercle is known as the dorsal tubercle of Lister. And this, guys, you can actually feel on your own hand. Try to palpate the radius bone over here and try to feel the styloid process, the lower projecting part. You will feel a gap over here. That gap is the wrist part, where the radius is ending and the carpals are beginning over here. You feel the bone over here, and then you feel a gap over here. So that you are feeling the styloid process of radius. Then you rub your finger over here, you feel the dorsal tubercle. Over here, you will feel the tubercle. And in front, you don't feel any tubercle, you feel smooth, and by gentle palpation, you will feel the pulsations of the artery. All this well understood. Now, this rounded head over here, let me tell you its clinical importance also in the beginning only. As we discussed earlier on, that there are two movements, supination and pronation, and which is contributing more, radius or ulna?
Radius.
Radius is contributing more than the ulna. So it means that during supination or pronation movement, the contribution of radius is more. That is that suppose this is the radius over here, right side. So during supination, pronation, the radius will rotate like this. It is going to rotate like this. Can we feel the rotation is the point. We can see the movement, but can we feel the rotation of any bony part? The answer is yes. Where? Yesterday we talked about the elbow region. This is the elbow part, that is the olecranon process. This is the medial aspect, that is the lateral part. Now feel the lateral epicondyle over here, coming down from the humerus, you feel the lateral epicondyle. Below lateral epicondyle over here, if I just try to put it my hand like this, I am touching on my radius head, meridial head. That is this circular part, this disc-shaped head. This disc-shaped head is just below the capitulum. So here we have lateral epicondyle, and here I am touching over my radial head. Now, with me touching over the radial head, I try to rotate my right forearm in a supination pronation movement. And with these fingers, I will feel the rotation of the head of the radius. Try to do it. Once you do it, then you will never forget. So feel the radius head, or just put 3-4 fingers and do the movement like this. You will yourself, at after a time, you will feel, okay, some bone is rotating around my fingers over here, or in this location. That rotation is the rotation of the head of the radius. Okay, understand these few points about the radius. Now, let's come to the typical bony part, how we explain. A typical long bone will have upper end, that is the head part, and a neck below it, like in humerus we said a head and neck. And then it will have a lower end, and between we have a shaft, simple as that. There are a lot of muscles being attached over here. That also we'll see in the images. But that forms the last part of the whole discussion. What are the muscles, name of muscles? Because those once you understood the bone, muscles also you will understand. But coming to the parts, upper end over here, it has a head, below head, it has a neck. This area is neck. And then you will see a tuberosity over here. Let me try to show you. Okay, this is the area below the neck of the radius. Okay, let me put it like this. Can you see a prolongation over here or elevation? That is the
Yes, sir.
tuberosity known as the radial tuberosity. So this tuberosity in the radius bone will be known as radial tuberosity. Okay. Now,
Okay, sir.
when the bones are formed, when the bones are formed in embryonic life, when at that time the bones are very smooth, there is no tubercle tuberosity at that time. So what could have led to the development of any tuberosity or any tubercle in any bone? It means that there
Some
should be,
stress.
there, pardon?
Some stress or force, sir.
Yeah. So something should be attached over here which should be pulling this bone. And with the chronic or with prolonged pulling slightly daily, sometimes it produces an elevation on the bone. So now the question comes, as an examiner might ask you, okay, what structure is this? You will say, sir, it is a radial tuberosity. It's a very good. Then the other question will automatically, it's a reflex question. What is attached on the radial tuberosity? There should be something attached, else there is no point in having tuberosity. Like we learn any tubercles, any processes, there is something attached over there, else there is no point. So if there is a tuberosity, there should be something attached over here. And here we have the attachment of the tendon of a very, very important muscle. This muscle over here, biceps brachii. So biceps brachii attaches onto the radial tuberosity. Very important question you should know. So this thing should not forget. Okay, let us see more as you go down. How do we find the side of the radius? So upper end, let us just review it. Upper end having a disc-shaped head, a narrow neck, while lower end is expanded, having a styloid process. Let me just clarify the styloid process. It faces where? It faces laterally and downward. So it is laterally and downward, outside. You can feel it actually, you can palpate it. This part that I'm touching right now at the tip of my right radius styloid process. This is my right radius styloid process. Then lower end anterior surface in the form of prominent ridge. Posterior surface presents 4 grooves for the extensor tendons. Posterior surface, we have seen that there are grooves. It also has a tubercle, and that is famously known as the dorsal tubercle of Lister. Don't forget this name. It is frequently asked. Dorsal tubercle of Lister. Okay. Then there are features over here. Head with articulate with the capitulum. It finds a socket for the radial notch that we'll see. Neck has a ligament about the annular ligament that we'll see once we see the ulna also, because they both will correlate well. Or we'll see just now. Radial tuberosity will present just below the middle part of the neck. Now let me bring the ulna also for you. Okay, this is the ulna over here. So now what happens is, let me first show you. Have you felt this movement of the head of radius? If not, then try. If you do it once, you'll never forget. So what actually happens is that during supination pronation, this head is rotating like this. This head is rotating like this during supination and pronation movement. So when this head is rotating, it means that it should be free. And therefore, what happens is, if I bring this the ulna over here, if I bring this ulna and this radius over here, then actually what happens is, okay, here let me show you. This is the upper end of ulna. Okay, just look at the upper end of ulna over here. This process over here is the olecranon process, and this anterior projecting process lower down is the coronoid process. Have a look at on the sides also. This is one side. This is a you can say the lateral view. This is the olecranon process, the tip of the elbow over here. It is this is olecranon process. While this process projecting forward over here, this one, and this is known as coronoid process. Okay, but let me show you over here. At this point, there's a small notch. I hope you can see it.
Yes, sir.
There is a small notch. This notch is for what? This notch is for the attachment of this rounded head of radius during movement, the same movement, supination, pronation. Got the point? This is how
Yes, sir.
supination, pronation is done. And therefore, we say that during supination, pronation, it is a major contribution of the radius in the movement wise. And here it is rotating like this. So now there has to be a ligament like this. Now there has to be ligament, and the ligament is attached onto the ulna. So what happens is there is a ligament which goes from the anterior margin of the radial notch. So this notch will be known as radial notch of ulna. It is in the ulna, but it is a notch for the radial head. So we call it as radial notch of ulna. So from this anterior margin of the notch, there is a circular ligament which will go around the head of radius and will come back and attach onto the posterior margin of the radial notch. It goes along like this. And inside this notch, suppose this my, if I keep my finger, then this is the notch, and suppose I put it like this. Okay, then this my index finger, right hand index finger, is the annular ligament. This is known as annular ligament. Annular means what? Annular over here. Annular means ring shape.
Ring.
Right? So it forms a ring shaped ligament. What does it do? It actually fixes the head of radius and also keeps it free. Free meaning by that ligament, if I ask you, is this ligament attached to radius? Attached to radius. Is this ligament attached to radius? Answer is no. It is not attached to radius. It is not attached. It is close to the radius, but it is not attached to radius. If it was attached to radius, then the movement of the head of radius, the movement of supination, pronation would not have been possible. So it is covering the head. It is not attached to radius. It is attached to the notch at the ulna. This is the very, very important annular ligament. Now, why it is more importantly being taught every time is because the reason there is a very important clinical situation. What is that clinical situation? Related to this annular ligament. There is a condition known as pulled elbow or nursemaid's elbow. This is a clinical condition. What happens in this condition is that in small children, 5, 6, 7 years of age, if you pull them up holding their hand only, then this head of radius might pull away from the, suppose this is the hand over here, and the child is keeping the hands like this because obviously the height is small and you are lifting the child from the hand. So suppose you are lifting the child from here. This is the lower end, right? You're lifting the child from here. Then what might happen is that this head of the radius, it might slip away from the annular ligament. Okay, this head of the radius, it might slip away from the annular ligament because small children, small bones, small ligament. And that is condition is known as pulled elbow. Now the head of the radius is dislocated from the annular ligament. You have to, by maneuver, you have to again supinate and insert the head into the inside the annular ligament only. There's no surgery is needed, but simple maneuvers are done. So that condition is known as nursemaids or pulled elbow. It is seen in children normally less than 8 years of age because of the anatomy, the lower size of head of the radius, the lower size of annular, and easily prone. So remember that is very, very important clinical condition for develop. Okay. Now, similarly over here, as you have seen that there is a radial notch and the radius is moving like this. Similarly, in the lower end, as you come at the lower end, now look at we are doing it simultaneously. Look at the upper end of ulna. It is how huge. It looks so dreaded also, no? There's a big olecranon process. There is a coronoid process. And now look at the shaft of the ulna and look at its lower end. It is so small. And compare it with the radius now. Now look at the upper end of radius. It is smaller. And look at the lower end of radius. It is bigger. So they both are counterpart to each other. They are counterpart. Counterpart meaning by that upper end of ulna is huge, but our upper end of radius is small. And the lower end of ulna is so small and lower end of radius is huge. So like in the upper end, we saw the head of radius and this ulna. Simultaneously at the lower end or at the wrist region, we have over here the rounded part that is known as the head of ulna. This rounded head. Very, very small. We have broken over here. That is a styloid process attached over here. Very small. But we have this rounded head. And this rounded head will attach onto the ulnar notch of the radius. Like we had the radial notch of the ulna in the ulna. At the lower end of radius, remember this radius at the lower end. Here you can see over here, this concavity. This is for the head of the ulna. And this forms the inferior radioulnar joint. Like this formed the superior radioulnar joint over here. Okay. And this over here below, it will form over here the inferior radioulnar joint. Okay, this is the whole point that how there are these two major joints between radius and ulna. There's a superior radioulnar, there's an inferior radioulnar, and then the third one is the interosseous membrane, which is also known as the middle radioulnar joint. Middle radioulnar joint. That is actually our interosseous membrane. Okay, basic idea is this. Okay, let us see more. Shaft has 3 borders and 3 surfaces. We're not going to detail of it, but for understanding, remember that in radius we have a sharp. This middle interosseous is the sharper border. And just by lifting the bone, it is self-relevant how sharp it is, and it will help understanding. And the surfaces, and this is the bone over here, the features over here. This is, we have reached the ulna now. Okay. We have reached the ulna now by radius, and here we are looking at ulna. Okay, first let's complete the lower end now. Anterior surface, radial arteries palpated. This is all we know. And if we don't know, we should actually palpate. We should know how to palpate the radial artery. And posterior surface, we have a dorsal tubercle of Lister. Again, frequently asked question. Medial surface occupied by ulnar notch. Because medially you have the ulna bone. So this is about we are discussing the lower end. Upper end, ulna had a radial notch. Lower end, radius will have the ulnar notch. Lateral surface, styloid process, we have seen. And inferiorly over here, I can look at the radius inferiorly. Which bones will come over here? It will be the carpals. Okay, try to understand. This is the lateral styloid process, and this is the lower surface or the inferior surface of the lower end of radius. So which carpals will come and attach over here is another question. There are 8 carpals, so the proximal row carpals. Which carpals? The proximal row carpals will come and attach over here. The proximal row carpals from lateral to medial. We have 2 main carpals. One is the scaphoid and one is the lunate. So this over here, inferior surface over here, laterally we have the scaphoid attached over here. And medial to it, we have the lunate bone. So these 2 attachments or these 2 grooves or these 2 not group but notches over here, they are for the 2 carpal bones, scaphoid and lunate. Okay, scaphoid lunate. So do remember this. Okay, so this is very important. And let's now come to the attachments. As one or two, I already told you, biceps brachia into the radial tuberosity, very frequently asked question. Okay, attachments better you can understand with looking at a diagram. They look at the diagrams of the radius on both the front side as well as the back side. Okay, this is the anterior part, and that will be the posterior part. Okay, they're all the muscles which are basically attached onto the radius front and back, and basically these are all the forearm muscles. This you will understand better. Just read their names, that is sufficient. But this you will understand better once we reach the gross anatomy of the forearm where we will see all the muscle names in detail. But remember over here, laterally we have the pollicis muscle will be there, supinator muscle will be there, pronator will be there, abductor will be there, pronator teres will be there. These are all are muscles of the forearm, and their tendons will go down mainly into the hand. Or if the muscle is coming from above, then their tendons are inserting, like for example, biceps brachii. The muscle is a muscle of the arm and its tendon is going to the radius. Okay. Okay. Now there are a couple of deformities also. Remember this dinner fork deformity. What is dinner fork deformity? Very important over here and right over here. Have a look at this. Actually, what happens is in dinner fork deformity, understand that this is the wrist part. And guys, understand dinner fork deformity is one of the most common deformities or one of the most common result of fractures, and those fractures are known as Colles fracture. So what actually happens is in old age, when there is also osteoporosis due to many reasons, if there is a fall on an outstretched hand, which is not that uncommon, suppose anyone is falling down due to any reason, our reflex is our hand will support the body so that our face does not strike the surface. And in those cases, what happens is when there is a fall on an outstretched hand, then what happens is proximal to the lower end of radius, there is a breakage or there is a fracture of the radius. As you can see over here, radius. And then what happens is that this part of the radius, it moves backward. Now, have you seen a fork? I hope you all must have seen the fork. You see the fork, if I twist around the fork appears somewhat like this. Okay. The fork appears somewhat like this. And this happens to the radius. The fracture is actually over here. This is the site of fracture, and the distal end of radius is pushed backwards. It's pushed backwards or posteriorly. The hand looks or the X-ray image. It might look like a dinner fork. So it is known as dinner fork deformity, and basically it's a Colles fracture. And opposite of Colles is known as a Smith's fracture, when this whole displacement is anteriorly. Although Colles is much commoner than the Smith, but yeah, Smith fracture can also occur. The site of fracture is quite overlapping, but the direction is opposite. In Colles fracture, the distal end goes backward, so it appears like a dinner fork. In a Smith fracture, the distal end of the fractured part will move forward or anteriorly. That is the basic difference. So remember this basic difference over here. Okay. Let me last time also show you the radius bone. Just revise it quickly. There will be features which will come on. So this is the radius. So first of all, identify the radius. Looking at the upper end and the normal shaft and a wide end or broad lower end. Then comes the side. Feel for the interosseous border. Okay, feel for the interosseous border. And this tuberosity will also be facing medially. Remember, this is the lateral bone of the forearm. It could be of the right side or it could be of the left side. So, okay, so you have seen the upper end, you have seen the radial tuberosity, the biceps muscle, and as you go down, you feel the interosseous border and make it to face medially. Then as you go down, anterior surface should be smooth. So this has to be placed anteriorly, medial border over here, and then try to put it on your own right forearm. This is the right radius. And then also focus posteriorly over here. We have the tubercles, simple as that. Then few 4 or 5 muscles, even if you know, then it is sufficient. This is the head. This is superior radial nerve joint, inferior radial nerve joint, supination, pronation, biceps brachii. Other muscles are here, tubercles over here. We palpate the radial artery over here, and radial artery does supply it. It's a fracture. We discuss Colles fracture. There are other fractures also, Monteggia fracture and Galeazzi's fracture, all that fracture. But yes, at least remember Colles fracture. Now, the counterpart, we come to the ulna bone. Ulna, we have seen that, okay, ulna upper end is huge. And therefore, let me make a statement over here that there are 2 joints. How many joints? There are 2 joints which are related to the forearm. What are those 2 joints which are related to the forearm? Very simple. The upper part of the forearm is forming the elbow joint. And the lower part of the forearm that forms the wrist joint. Now in the elbow, the major contribution out of radius and ulna is ulna. Ulna much more than radius. While in the wrist joint, the radius is the main contributor over here. Brackets I'm writing, ulna does not participate. Now you might argue that ulna, why it does not participate? How is it even possible? I'm writing that ulna does not participate in the formation of wrist joint anatomically. And what actually happens is, as you can see, the lower end of ulna is so small, but yes, it is going to the wrist area. So it should participate, but technically it does not. What happens is that between this lower end of ulna and the carpals below, you have a articular cartilage or articular disc over here. So there is an intervening cartilage. So this bone over here does not directly forms the joint. Even if you look at an X-ray, then you will always see that there is a gap below the lower end of ulna. It is not directly in contact with the carpal bones over here. While in radius case, they are very close to each other. So ulna does not technically participate in the formation of wrist joint. This you should understand. While in elbow, major contributor is ulna. Therefore, you can see the prominence of the upper end of ulna. As I already told you, what are upper end and lower end and shaft. These are three main things. In ulna, understand the upper end in detail, a bit detail. Now I am showing you the side view. This is the anterior view. So anterior, there is you can see a concavity. What is that known as? What is its counterpart in the humerus?
Trochlea.
Very good, trochlea. So this notch will be known as the trochlear notch. Like we had capitulum and radial head on the lateral side. On the medial side, we will have the trochlea from above, and this forms the trochlear notch. Now let us see the humerus over here. This is the lower end of humerus anteriorly. Okay, this is anterior. Now this hole over here, can you see this hole rounded? This lever over this is hole is trochlea. And this small rounded part, this was the capitulum. This is trochlea. And what happens to this trochlea? Understand, it fits over here like this. So, and again, look at the trochlea separately. Look at the trochlear notch and try to understand how does it fit. And this is flexion and this is extension. So it is occurring around what? The trochlear notch and the trochlea over here. And if I move it posteriorly over here, then can you see this olecranon process over here? And if I bend it, can you see the prominence of olecranon? And see it over here. This is the same thing. So in elbow, you can understand how big is the contribution of the ulna contribution. Look at the trochlear notch and the trochlea over here. Look at the trochlea from all the sides, front, below, and posteriorly. Have a look at the entire trochlea and look at the trochlear notch. So you've seen the trochlear notch, and posteriorly you also have seen the how the this olecranon process fits. What was this fossa? Yesterday we talked olecranon fossa. So in an extended elbow, this olecranon process is fitting inside the olecranon fossa. And once you flex it, olecranon process comes out of the olecranon fossa and it forms the prominence like this. So if I look at my elbow only, my elbow is flexed. So this my olecranon process of ulna, it has come out from the olecranon fossa of the humerus. So it is prominent now. And if I extend it like this, now this prominence is gone because it is now going, it went inside the olecranon fossa. So now one thing is clear, this big part is olecranon process, this is trochlear notch. Now in this trochlear notch, you are seeing one more small process coming out. This is known as a coronoid process. Let me put it simply over here, that if you look at this image in the camera also, then you will understand that, okay, there's a huge olecranon process, okay, and there's this small coronoid process, and between you have the trochlear notch. This is the trochlear notch. This is the whole basic story over here of the upper end of ulna. Again, if you come to the shaft, you can see again recognition of the bone is very simple. This sort of features is only seen in ulna, so you can identify ulna. Then obviously comes the side. In this, understand the lower end is so small that sometimes you might confuse that, sir, I am not able to see the styloid process. It might be broken also, like in this case. You see, this area is broken. It happens during procurement of the bones. Small damages, they are inevitable. They will occur. But what will not break is the interosseous border. So again, you try to palpate the shaft. And this part here, you can see the interosseous border. You can feel it. Okay, if I might show you, then I hope you can see like a knife over here. A sharp edged. This is the interosseous border. So this will be facing medially or laterally. ulna being a medial bone. And this introitious border will attach the introitious membrane. So this border, will it be facing medially or laterally is the question. So if it is of the,
Laterally, sir.
it will be facing,
Laterally, sir.
very good. Because laterally as is the radius one. So you know by now that this, okay, this part has to go laterally. You also know the anterior aspect, trochlear notch is anterior, and you are seeing, okay, this border is going laterally. You try to fit it on your own hand or on own forearm for confirmation. You know, right? It is the ulna of left hand side. It is the ulna of left hand side. This is the medial. Laterally, I will have the left radius. This is the introitious membrane will be attached over here. And then find this lower part. Posterior medially, I have this part. This is the styloid process. Small part of styloid process you can see, although it is a bit broken. So identification becomes simple. Then also, apart from introitious border and this anterior part, compare it with the radius. In radius, we discussed the common introitious border. But in that case, radius, we had the rounded head. So we took the help of dorsal tubercle of Lister in radius. Here we took the help of simply notches facing front. Other thing that can help you is looking at the radial notch over here. This notch will again, like the border, will face laterally because it is for the attachment of the head of radius. So this ulnar, this radial notch over here and this introitious border, they both will face laterally. So now you're confirmed the side. Side confirmation is, guys, very, very important. As yesterday also I told. The Viva won't go forward if you are not aware of the name or the side of the bone. Only then the Viva or the questions will go forward. Else the examiner will very gently ask you to keep the bone on the table and pick up some other bone over here. Because, right? You are not aware of this, right? So these two things. And after this, okay, let us see a bit more from the notes perspective. It is a medial bone. It has two processes, a narrow, rounded, lower and fine. Concavity directed, so side determination again important. Hook-like concavity directed forwards is the point. The lateral border of the shaft is sharp, that is the introitious border. Pointed styloid process, if you can find it, then very good. Lies posterior medial to the rounded head. Features again olecranon process and coronoid process of upper end and the trochlear and radial notch. So these two notches and two processes we have seen. Then this is beautifully crafted table over here or flowchart showing us the three things: upper end, shaft, and the lower end. These are the three parts of any long bone, any typical long bone. Some features over here, surface, and all that. Okay. Okay, fine. The basic features. Shaft again will have three borders. Do understand the introitious or lateral border? Yeah, continuous with the supinator crest. Supinator crest where the supinator muscle will come and attach. Don't worry about all this. Okay, now surfaces. Nutrient artery, do remember, nutrient artery is derived from the anterior introitious artery, and this ulna is basically supplied by the ulnar artery, and radius was supplied by the radial artery. Do remember that also. What about this introitious artery? Now, sometimes these things might confuse you, so let us take 1 minute over here to understand artery. Let me try to draw the artery for you guys. We all know about the brachial artery that is coming into the arm region. Brachial artery that is in the arm. This will divide into two arteries, radial and ulnar artery. Ulnar artery, guys, then what happens is it gives off one more branch. Let me change the color. That is known as common interosseous artery, common IO, interosseous artery. Now, this common interosseous artery divides into another two branches, anterior and posterior interosseous artery. This posterior interosseous artery is going where? It will be going where? It will going posteriorly. While this anterior interosseous artery is the one that runs anteriorly. Therefore, here you will see the anterior surface is related to the anterior interosseous artery. The posterior interosseous artery over here, it will go posteriorly into the extensor or the posterior aspect of the forearm. And anterior interosseous artery remains in the anterior aspect of the forearm. Okay, lower end has this head and striate process. Head articulates with the ulnar notch of the radius, as we have seen. I will show you again. Again, have a look at the lower end of radius. This over here was the ulnar notch. So this is facing medially. So you know the styloid process is facing lower down and laterally. This is the ulnar notch. What will attach over here? The rounded head of the ulna. The rounded head of the ulna is going to attach onto the ulnar notch of the radius. Okay. Then you have the ulnar artery also over here. Attachments again. For attachments, don't worry too much. Look at the diagram 2-3 times and then try to read about the individual muscles. Therefore, I'm not discussing in detail about the muscles. Was telling you the name of the muscles right now, it is attached over here, and then you will not read the details of the muscles, you will forget it. So just look at the names, read the names first of all, and then as the forearm gross anatomy will come, they will come in detail. All the muscles will come in detail. Okay, so here are all the muscles, and this was about the ulna over here. This was about the ulna over here. Now let me show. Now apart from this, there's one more very important point which I wanted to share with you guys. And what is that? I hope you can see this image over here. Yes or no?
We can see.
Yes, you can see. Very good. Just a second. Right. So as what we can see over here, there are two or three images. On the left hand side, we are seeing the humerus over here. We are seeing the humerus over here. On the middle part, we are seeing the radius, and the right aspect, we are seeing the ulna. Okay, let me just try to use the pens over here. So I'm not able to use it. Just a second. Just give me 1 minute. Okay, no problem. Let us go like this only. So there are three images. On the left hand side, we are seeing the humerus, upper and lower end. On the middle diagram, we are seeing the radius, upper end and lower end. You can even identify now the radius having the rounded head, and the lower end you can see the styloid process. On the right triangular, there's a triangular area of diagram. We are seeing the upper and the lower end of ulna. Here you can see the ulna, the trochlear notch, and all that. Now, what is the CA and EL in all the diagrams? The CA is the capsular attachment. Capsular attachment. So capsule is an important part of the synovial joint. So CA is the capsular attachment. And this EL over here are the epiphyseal lines. EL over here are the epiphyseal lines over here. So what does it signify? There's nothing to cram over here, just to show you some clinical implications over here, and how important things become. Capsule attachment is the attachment of the synovial joint capsule. So like upper end of humerus, it will have what? The shoulder joint. And lower end of humerus will have the elbow joint. Same if you look at the middle diagram of radius and the right diagram of ulna, their upper end will have the capsule attachment of the elbow joint, while the lower end will have the capsule of the wrist joint. Simple as that. Okay, so capsule is the capsule. Now we come to EL. EL, what is EL? Epiphyseal line. So at the EL, what happens is that the metaphysis fuses with the epiphysis, and that area is known as epiphyseal line. That area is known as epiphyseal line. Now, in any of the diagrams, if you see that the EL or the epiphyseal line is inside the capsule, I repeat myself, if you are seeing the EL epiphyseal line is inside the capsule, then it means that any infection of the joint will go to the metaphysis or vice versa. Metaphyseal infections will create problems for joint because the metaphysis is inside the capsule. So if there's a problem in the metaphyseal, then there'll be problem in the joints. Joints problem meaning by arthritis, simple as that. We call it as septic arthritis. That is our arthritis due to infection. So bony infections might lead to joint infection if the epiphyseal line of the bone is invading inside the joint line. Simple as that. So in all of these three diagrams, where do we see that the epiphyseal line is totally inside the capsular attachment? There we have to be aware that infections might lead to the one infection might lead to other infection. So if we start from the left diagram over here, we are seeing this epiphyseal line is partly intracapsular. So this is the green line is the capsular attachment, right? So you can imagine the shoulder joint capsule is over here. So in the left diagram, as you can see, the upper end of humerus, a very small part of epiphyseal line is entering inside the capsule, partly intracapsular line. So there's not much to worry over here. You come to the right, in the humerus only the lower end. Here also, this is actually the joint is situated where? The joint is situated elbow, it is situated lower down. Here the joint was over here at the upper part. Here the joint is low down. Here you can see the epiphyseal line is mostly inside the capsular attachment. So yeah, here you have too much of risk. Similarly, if you look at the middle diagram, the radius upper end, this will form the elbow joint. You can see the epiphyseal line is completely inside the capsular attachment. Completely inside. Epiphyseal line is going through the neck. Capsular attachment is reaching the radial tuberosity. So here you can see it is completely inside. While if you look at the lower end of radius over here in this image, you'll see the epiphyseal line is away from the capsular attachment because the joint is below. The wrist joint is below. So it is problem free. So upper end of radius and this lower end of humerus are having some issue, can have some issues if there occurs any infection. Similarly, in the ulna also, if you see the capsule attachment is away from the epiphyseal line, and here there is a very small capsule attachment, the lower end of ulna, because basically it does not technically form a part of the wrist joint. Epiphyseal line is a bit away only. So problematic over here is the upper end of radius. That is very, very problematic, and including the bit of lower end of humerus also. So these two things over here, these two images, the lower end of humerus and upper end of radius. So remember to write this. They can have issues. They can have issues later on. One infection might lead to other infection. Bone infection can lead to arthritis, or osteitis can lead to arthritis, or vice versa. That is the whole point. Okay. Now let us see some MCQs also. As we are proceeding forward, let us see some MCQs as well. So here's the first MCQ, that which of the following statements about the interosseous membrane is true? I'll read the options for you guys. Option A is it forms a proximal radial joint. It serves as the attachment for deep muscles of the forearm. It prevents pronation and supination. It is absent in the lower third of the forearm. So which statement is true regarding interosseous membrane? Or in other words, try to rule out the wrong statements. Like for example, statement number first, it forms a proximal radial joint. That is wrong. So it forms which radial joint? It forms the middle radial joint. Second, it serves an attachment for the deep muscles. Absolutely correct. That also we have seen. Because there are a lot of muscles in the forearm. So second option is correct. Let us see the third option. It prevents pronation and supination. Now this statement, third statement, is partly true. It does not prevent, it actually it hinders. It limits the amount of pronation and supination. Because it is between radius and ulna only, no? It will limit how much supination and pronation can be done. It does not prevent totally. Somewhat it limits the total amount of supination pronation. Fourth, it is absent in the no, it is present throughout the forearm, so it is present in the forearm, lower third of forearm also. So answer over here, correct statement is option number B over here. Right? Let us look at the other second question over here. Okay. Right. Which muscle attaches to the radial tuberosity? Now this, I think, luckily we have done this because muscles images we have seen. So it is the biceps brachii muscle, the main muscle over here in the front of the arm, whose tendon goes and insert into the radial tuberosity. Now this has one more practical implication. Let me tell you that also. See, this is supination, that is pronation. Can you see the movement of the forearm? This is the supination pronation movement. Now once you do the supination, you will feel the contraction of biceps over here. This is normal hand, pronated hand. And if I'm doing supination, you can see some movement. Do it on your own. Therefore, biceps is also a strong supinator of the forearm. Biceps, a normal function is not only flexion of forearm, its other function is supination of forearm also. That is why biceps attached to the radial tuberosity. It gives you one more hint over here. Now, in the question that which artery primarily supplies blood to the ulna? Now that we have seen already, that there was an interosseous artery, but all that interosseous arteries, primarily if you talk about, it is the ulnar artery that will primarily supply the blood to the ulna. And vice versa, the radial artery will supply blood to the radius. So if the question comes, which artery primarily supplies blood to the ulna, brachial, radial, ulnar, or anterior interosseous, you have to go with the answer of ulnar artery. Let's see one more question. Fracture of the shaft of the radius typically affects which nerve? That will be difficult right now, but yeah, let us try. The options are radial nerve, ulnar nerve, median nerve, or musculocutaneous nerve. So if there's a fracture of shaft of the radius, let us see options. Radial nerve. See guys, radial nerve we normally see in the arm only. Then the radial nerve actually divides and we have the posterior introitious nerve and the superficial branch of radial nerve. So nothing directly related to the bone. Ulnar nerve will remain more or less on the medial aspect, not to the radius side, but to the ulnar side. Median nerve, on the other hand, yes, it is close to the radius bone, and there are chances it might get ruptured. Musculocutaneous nerve, again, musculocutaneous actually supplies the arm muscles only. Then, as it goes down into the forearm, it only supplies the skin in the forearm region. So, again, the skin area will be away from the bone. So, to rule out other options over here, the answer over here will become option number C, that is the median nerve. That is the median nerve over here. So, median nerve, if we rule out, answer comes as the median nerve. Okay, which structure is located within the anatomical snuff box? Another very, very important topic of anatomical snuff box. I'm not going into details of it because it's a different topic. And that we'll do once we do the extensor compartment of the forearm. Because then all the tendons will come. But basically, let me just show you. This is the, if you extend your thumb, you will feel a concavity over here. This concavity over here, this is the anatomical snuff box. And the major content of the anatomical snuff box over here, as they're asking, the options they have given: radial artery, ulnar artery, superficial branch of radial nerve, or the median nerve. The major content of the anatomical snuff box.
Radial artery, sir.
Very good. It will be the radial artery. So can we palpate the radial artery in the anatomical snuff box? It is quite deep. So in the box we can't palpate, but yeah, we can palpate over here, but then it goes behind and goes inside over here. So the only main
Yes, sir.
content of the snuff box is the radial artery. So answer over here will be option number A. Next question, which of the following movements is primarily restricted by the interosseous membrane? I guess we have discussed in the first question. Option number C, it prevents supination pronation. There I told you it might hinder. It won't completely prevent. It might restrict, as the question says over here. So which movement primarily restricted by interosseous membrane? Answer will be supination pronation. If you look at the other options, flexion extension they have given, abduction adduction of the wrist they have given, flexion and extension of the wrist they have given, and supination and pronation. The answer is basically our supination and pronation of the forearm. One more question. The head of the radius, upper end, articulates with which structure of the humerus? I guess this you guys have already answered. That it is the capitulum of the humerus, which will articulate directly with the head of the radius. And the trochlea goes along in the trochlear notch of the ulna. So answer is A, option capitulum. Other options are trochlea, choroid process, and olecranon fossa. It is the capitulum. The distal end of the ulna articulates with which bone? Distal end, that is the lower, this rounded part of the ulna over here. That articulates with which bone? Actually, directly there is no bone over here. It is the articular disc over here. So distal end of the ulna articulates with which bone? We have options like lunate, scaphoid. Now option number A and B, lunate and scaphoid, they will go where? They articulate directly with the radius. Look at the radius lower end. Okay. Yes, radius. Option number C, does it articulate with the ulna? Obviously. Why? Because in radius lower end, we have the ulnar notch over. This is the ulnar notch. So here the head of the ulna will come. It forms which joint? It forms the inferior radial ulnar joint. Fourth option is capitate. Now guys, capitate is a distal row of carpal bone. It is found in distal row of carpal. So capitate cannot articulate either with radius or ulna. Because we have four carpals in the proximal row: scaphoid, lunate, triquetral, pisiform. Then your distal row, trapezium, trapezoid, capitate, hamate. So capitate comes under the distal row. So it does not articulate with any of the radius or ulna. So answer over here will be straightforward: radius, forming the inferior radial ulnar joint. And that you have seen helps in supination pronation. One more question, that which ligament stabilizes the proximal radial ulnar? Now, I will give you a hint over here. This was the head of radius, and okay, remember the movement of the head of radius, supination pronation. So which ligament was there? A ring-shaped ligament was there. Very good. It is the annular. Annular means ring shape. It is the annular ligament. Other options, we look at it: ulnar collateral, radial collateral. They are the ligaments of the elbow joint. They actually are on the sides of the elbow joint. On the middle side, we have the ulnar collateral, lateral side, we have the radial collateral. So they are forming the sides of the elbow joint and interosseous between the two bones. Okay, one more question over here, that which fracture is known as a dinner fork deformity, commonly affecting the radius, distal radius. So we have seen the image also. It is the Smith's fracture. Sorry, the Colles fracture. Smith is just the opposite. Colles fracture, guys, is one of the most common fractures that you will see in orthopedics OPD also. So dinner fork deformity is Colles. Opposite of it will be the Smith fracture, option number D. Then there are Galeazzi and Monteggia fracture, where you have the fracture of the shaft of the radius, and Monteggia, I guess, there is fracture of the shaft of ulna with some dislocation of the radial nerve joint. So they are different altogether. But dinner fork deformity can easily go with Colles fracture. Colles fracture will be the answer over here, right? So this was the MCQs. I hope we had some insight on these two bones and their clinical applied. So go read them in detail. Also try to have some bones in your own vicinity so that you can have a look at them. Okay, so that's all. I hope you enjoyed, and any queries, do ask in the comment box. Okay, Sam wanted to discuss something. Okay.
Sir, can you share the PDF?
Yeah, sure.
Thank
In,
you, sir.
in the comment
It
box.
was very nice interacting with you, sir.
Okay, thank you so much.